thing I want to talk about is the concept of space, staff, and stuff. So these are universal planning principles, and just because there's the word pediatric on these are easily adaptable to adult care environments. I always think that the best thing you can do is find what we call dual use. So if you can find a way to make your everyday work for you every day and flip a switch and have it work in a response, that's the type of material that you want to promulgate and communicate about, because it's going to help you anytime you need it. So for this, I encourage folks that have connections in the adult care world to think about how might some adaptations of this work for that community, because it's the same process. The people are just little, but it still works. And also there's a lot of shared resource among pediatric and adult, and typically there's I don't think symbiotic is the right word, but sometimes mutual pull on the same shared services, especially like dietary or laundry or any of those kind of things. And so we really are looking at a holistic operation and all of the different tentacles that come with it. So if you open up the Pediatric Surge Toolkit, which is this one, it has an insert in there that's white. That's how you'll tell there's a difference. And you turn to page 4, not the spiral bound. What you'll see is some commentary about the 4 planning worksheets or tools that are in this product. And the video talked a bit about this. I really encourage you to consider hospital-wide planning from the get-go. How many of you all have an emergency management committee as part of your hospital? Okay. So think about how you can take this work and share it and divide out the work. Are there people that should join your committee that maybe aren't, but you should engage in a more routine fashion to do this work, even if they're there for a year? You know, that gets you what you need in a more routine fashion. Let's see. You'll see on here, and it's on page 4 as well, the different parts of the toolkit are tied to different target audiences. So worksheet 1 is going to be more admin, director, C-suite, emergency manager, emergency management committee, really looking at concepts, policies, procedures, things that are going to guide a lot of the decisions that are made in the inpatient setting. So if it takes you a year to work worksheet 1, that's okay. But it's going to be a good foundation for you to be able to do the future planning. The second worksheet is your inpatient unit. Those are going to be your nursing managers, the folks that really know what's happening at the bedside and can figure out how they're going to squeeze, become the old mother in the shoe, you know, with all of the people like spewing out, but they'll be able to figure that out. And then worksheet 3 is the support unit. So the video talked about, you know, the dietary, the laundry model, but you're also looking at services provided at the bedside, like respiratory therapy, or PT, or any of those things where people don't really, the workers don't have a true like unit to work in. They float through the organization, and they're going to be taking care of more people, but how will they shape their experience? And then the last part is the surge planning worksheet, which is this insert in here. You'll see it. This is the entire example of the worksheet. So as you go through the pages, you'll see a comprehensive example that's described, and this is the roll-up of all of the example data. So you can follow that story through each worksheet to the surge planning toolkit, and then your flash drives have PDF fillable blanks. So you can fill this in on your computer for each of the worksheets, and then a blank. The Excel document has one tab as the example, and then it's a blank with multiple tabs for the rest. So let's see. So this is what we talked about earlier, the surge pyramid, which is on page 5. And this inverted pyramid allows us to work from the bottom to describe the current state or ground truth of our operations, and then build on layered, target-driven planning over time. So one of the things I learned when we started talking about this was I'm already at or over my licensed beds, or I'm not even close to supporting the bottom of the pyramid. And that's okay. Maybe where you start your planning is, how do I get to the license level? Everybody's gonna start in a different place, and that's totally okay. This is a blueprint. You're the ones that are gonna build the house, and that house is gonna look different for every place. The big thing I wanna highlight is the arrow on the right, or the left, is the surge capacity going up, and the role of the Oregon Crisis Standards of Care document. Does anybody not know what that document is? It's okay if you don't. Okay, so I'm gonna ask Carl to do a quick impromptu, real quick, on the Oregon Crisis Standards of Care, and he'll give you the rundown of it and what it means for peds.
Don? So there is a planning document for crisis standards of care that was put together by a lot of different people, a lot of groups have signed on to, and is really meant to be a sort of a statewide framework for crisis care. The whole idea is basically once you get past all of, once you've done everything you can to serve patients with either conventional and contingency care, and you need to really start doing allocation of resources in a non-traditional way. In other words, not first come, first serve. How do you do that? What are the important considerations for that? So that document is, it was recently updated, probably within the last 2 years, and is kind of the culmination of a lot of that planning. There are some pediatric specific considerations in there, notably in terms of trying to figure out what someone's expected mortality is, which is a key factor in terms of trying to figure out who is the most appropriate patient to get the next resource. Every crisis care document is limited in some ways, so it's not going to answer necessarily every question you have. It is a very valuable document to look at if you haven't, to familiarize yourself with, and it is the framework that we would be using if we needed to ever sort of go in that direction. The other thing I would say is every time I look at a crisis care document, the number one takeaway I come away with is do everything you can to avoid getting into that situation. And everything you do to prepare short of crisis care is going to help you stay out of crisis care.
Thank you. So the reason that understanding the structure of the crisis care guidelines is important is we decided to use the labels contingent and crisis in order to dovetail with the crisis care guidelines to kind of help people see here's where your interventions might be to help you move from the bottom up to crisis. So we wanted to try to go with something that was a little bit more standard in language that was familiar to individuals. So the last thing I want to point out is you know how at the top it says maximum number of patients the unit can support? We didn't want to really put a number on crisis level, because the thing we've realized is that your crisis level might be somewhere between 20 and 50, and that's okay. So you're going to need to do your planning and use your own judgment as to where is it that you really draw a hard line? Where can, after every intervention that you have done, everything that we can do, when do you say, we're closed? We have to change, we have to lose some patients somehow, but we cannot take anybody else. You're gonna figure out where that line is, and the power in that is the act of knowing, and then being able to communicate it to your colleagues and government to be able to say, we're not a resource for you anymore. What does that mean for everybody else? So that's the vision of what surge planning can look like from a bottom top. Okay, so with the 4 worksheets that are in there, you're going to see the robust example we talked about. And if you turn to page 6 in the toolkit, you'll see a description of the example hospital that we used throughout. And I'm just going to read these because I don't want to mistakenly speak. The example hospital is an academic safety net institution set on a campus in an urban area. The hospital is licensed for 585 beds. It's designated as a level 1 adult trauma center and a level 2 pediatric trauma center. There's an adult and a pediatric emergency department. The hospital has 4 critical care units: surgical, medical, pediatric, and neonatal, adult and pediatric care units, an adult and adolescent inpatient psych unit, an inpatient correctional care unit, and maternal services, women's care and labor and delivery, and then primary and specialty care outpatient services are also part of the organization. So we modeled this off of, we had a consultant that was heavily familiar with Denver Health. So this is based off of Denver Health's flagship hospital. So what we were hoping to do was to have a hospital example that was robust enough that we could get the examples to be extremely illustrative on how to use the tool. That doesn't mean that the example is going to speak to every type of hospital or issue that you face, but it allows us to be able to really show what the toolkit can do by choosing this type of example facility. I will say that one of my goals, longer term, maybe in the next year or so, is to see if we can find a community hospital that we could use as a companion to this example for a smaller scale picture of what this might look like. So I'm going to be looking for anybody that's willing to take us on and share their worksheets and share their planning process, because that's the story that really needs to be told. But we have to get it out into the public, in the community of practice, before we can tell that story. So let's see. So we identified actions for planning concepts in worksheet 1. And what we did was we looked at potential areas of the workforce that could achieve those planning items. So if you look at the front page of example of worksheet 1, what you'll see on page 7 is the space worksheet. And we're looking at the 2 items, the strategies that we want to do, and then the tasks that would be related to that strategy. This is not intended to be exhaustive. This is a starting point. Remember, these are all tailorable, so you can add in tasks as you identify them. And then the person assigned to the task, we went with what program in the hospital might have a stake in this strategy, and that's why we listed them there. And then we all like measurable objectives and activities, so we wanted to provide a space for accountability and tracking to make sure that those deadlines get met. And so you can go through worksheet 1 and see these are big ticket items, but the information that comes from them are going to help those inpatient planners take that to the next level, because these are questions that are likely going to come up from them or are going to help with the regulatory relief that may be needed to do this work if it actually happened. There's 3 kinds of spaces that I want to talk about that we created or were part of this. Non-traditional clinical spaces, non-clinical spaces like conference rooms, and airborne isolation infection rooms. So you will see in the Excel, in the bed numbers, you'll see some of that, and the definitions are in there. This was a way to provide some standard experience and language for folks, but if you have different types of beds that you want to track, you can add that in. But I just wanted to pull that out. And then worksheets 2 and 3 are somewhat similar. We're interested in worksheet 2 on the inpatient unit or ward, and the holistic view of what it takes to support surge across the hospital will come from number 3. The one thing about this dynamic process that is that it requires reaching back to people doing other worksheets as you fill out your own. The biggest piece of advice I can give you is don't make decisions based on assumptions. take the time to vet your assumption with whoever you think needs to do it. And if it causes you not to be able to make forward progress for 3 weeks while you wait for an answer, that's an investment in a better plan. So give yourself the space and the time to be able to vet those assumptions, because if you make 10 decisions on an erroneous assumption, it's not going to be a plan that's going to work. And then I anticipate about 50 to 60% of the content can be done independently of having to reach back to anyone. There are moments where you might need something, but overall, I think a manager that's been in their position for a while should be able to get through the majority of the product for the worksheet that they're on. And then the holding tank, which is the master Excel spreadsheet, really is a tool that allows for the hospital emergency manager and the committee to look at deconflicting and documenting the strategies and the decisions that were made. This is where some ethical decision-making by your C-suite is going to be needed to determine who really gets what conference room. What are we going to do with it? So the worksheets kind of put out what everybody's idealized state would be for that, and then somebody has to make the hard decisions around what it's going to really be and what's going to go into the final plan.